Dear friends, introducing SICOT Pioneer, Programme of Innovative Orthopedic Networking, E-Learning, Education and Research. What is SICOT Pioneer? A stratosphere built up of cloud and web-based infrastructure that enable communication, storage and on-demand utility of educational resource by and for our membership. The aim of the platform is to encourage cross-pollination and a virtual delivery of goals within the different pillars of the Education Academy and beyond for the global orthopedic population. Our traits include being disruptive, global, abolishing divide, inclusive and collaborative. The SICOT Pioneer Virtual Education Programme will begin in June 2020 and consist of a variety of educational event formats that encompass all orthopedic specialties, training, research and innovative practices.
A very good morning, good afternoon, and good evening, ladies and gentlemen. I'm Vikas Kanduja, consultant orthopedic surgeon in Cambridge, UK, and also the chair of the Education Academy in SICOT. And it is indeed a pleasure to extend a very, very warm welcome from SICOT Pioneer to all of you logging in from various corners of the world. Now, the topic for discussion today is complex primary total hip arthroplasty, and we are delighted to be collaborating with the Ukrainian Orthopedic Association for this webinar. And we would like to sincerely thank the stellar faculty that we've got, not only from Ukraine, but from all around the world who've given up their time for this webinar. Moderating this webinar with me today would be Dr. Stan from Ukraine, who's also the national delegate of Ukraine and has been the force behind setting this webinar, and Dr. Chahid, who's the chair of the Hip Arthroplasty Committee in SICOT. Now, we at SICOT Pioneer strive to make every session as interactive as possible. For the global audience who are following this live webcast, please post in your comments and questions in the discussion box in Panopto as we progress through this webinar, and we'll pick them up towards the end in the discussion. Our panelists would address some of the questions, and most of them would be answered on the chat box itself. Now, for those of you who are not able to join us live, we've got the option of the on-demand viewing on our educational platform called Panopto. So please do log in for the same if you're not able to join us live. Finally, as promised, we've also started our free paper session, and we've got two excellent papers today, and we'll start off with that. Once again, a very, very warm welcome to all of you, to our faculty, and a big thanks to Ukrainian Orthopedic Association, to our sponsors, AK Medical, and to all of you attending. Thank you very much. So we'll start with the first free paper presentation. That's on 3D printing technology in performing complex total hip arthroplasty following post-acetabular fracture sequelae with and without infection, a case series with a literature review by Dr. Kaniyanan from Chennai in India. Dr. Kaniyanan, please do share your screen.
Hi, sir. Okay. So hope everyone is able to see my screen. Good evening, everyone. Sharing a small series on complex primary total hip arthroplasty following post-acetabular fracture sequelae with and without infection using 3D print technology. The rise in the number of road traffic accident and the complex trauma is alarming, and complex primary THR in post-acetabular fracture is a well-known sequelae and a well-known treatment. It's complex because of the distorted anatomical landmarks and increased over time and the cost of the burden on the patient and the hospital. So our primary aim was to assess whether the usage of 3D printing technology and pre-planning reduces the overtime cost and reduces the complication rate. The retrospective study included 9 cases done between October 2015 to 17 with minimum 3-year follow-up period. They were divided into 2 groups, Group A with the signs of infection, increased ES without signs of infection, and Group B with positive signs of infection, either clinical and increased elevated parameters, ESR, CRP, and D-dimer. Case distribution, Group A included 5 post-acetabular fracture fixation with no signs of infection, Group B, 3 post-acetabular fracture fixation with signs of infection, and 1 neglected acetabular fracture following an infected DHS fixation removal. And 3D printing, 3D model prototype pre-planning was done for almost all the cases. And the Cretabot 3D printer was the one which we had in-house, and the ABS material was used to make the 3D models. Once the radiological investigation is done from the bone and soft tissue, the DICOM images collected from the CT and MRI. We use the Mimix 3D modeling software and Cura, the 3D slicing software, and we have a 3D printer of Cretabot. We made sure the CT scan of 0.6 done was included. This is one example in a 34-year-old male following a road traffic accident in 2014 January. After 18 months, he came with a painful hip and a wheelchair bound. In X-ray, it was looking haphazard and very complex, and the 3D model prototype pre-planning was done. Intraoperatively, we had the similar picture of intact anterior column and the column, and the posterior column and the column was deficient between 10 o'clock and 5 o'clock. And we used the femoral head in place of the augment, and the same size of the cup Sister 6TM shell was used with reduced in number of OT time and the blood transfusion rate. Another one example of a 30-year-old male following a road traffic accident in 1999. He had a painful hip gait with a colostomy bag on and a non-healing ulcer in his buttock. And most of the surgeons denied the total hip replacement for him. And after 17 years, he came to us and we did the 3D model. And this 3D model, once we have in the model, it looks so easy. It gave an idea of what is going to be the size of the cup, and also the short offset, horizontal offset ASTROM was planned and was executed intraoperatively. Another one example where the patient was wheelchair bound because of the polytrauma. One side he had a shaft of femur fracture with a nailing done, other side had a central dislocation, and with 3D printer model was done and a jumbo cup concept was used. Another one example where the femoral head was used as an augment and it was executed in the same way as we planned. Another one example where this had a doubt whether it was union or non-union, and the 3D printer also gave us an idea that it was completely united, and it gave the size of the perfect size of the cup and also the screws in which the direction where the good bone stock, and we executed the same thing. Here one case where the post-acetabular fracture fixation with the signs of infection. Clinically, there was no sinus or anything, but the increased ESR-CRP parameter blood. So the stage 1, we removed all the implants and antibiotic-loaded Siemens spacer with the gentamicin, and the gentamicin and vancomycin was kept, and a 3D model was done, prototype was done, and the same was executed as we pre-planned. One more case with the pre-planned DHS was done, and augment was used in place of to fill the posterior defect. 2 more cases we did the prototype, but because of the excessive infection and persistent infection, excision arthroplasty was chosen. So all were male patients. The mean age was 39.5, and expected the overtime was much reduced in both the groups, and no blood transfusion, and there was no reinvasion and row infection. The Harris hip score improved from 50.4 to 70.2 at the end of 2021. Thanks a lot.
Thank you very much, Dr. Kannan. Any questions from the faculty? Okay, I'll ask you one. How much does it cost? What's the financial implication for this?
So the total pelvis model costed around like 14,000, and the hemipelvis model costed around like 8,000. This was in the way beginning in 2015. Now the cost has been much reduced.
And if we translate it into US dollars, how much are we looking at? Just so that everybody gets a sort of vague idea as to how much it costs. 14,000 Indian rupees, right?
Yes, sir.
So that's about $140?
Yes, sir. Close to $150.
Zach, you could be producing these in India for sure.
That's cheap. I'll take 100.
Yeah. Okay, thank you very much. Our second paper is by Dr. Afshin from Iran. Please do share your screen. And he's going to be talking about total hip arthroplasty in association with digastric trochanteric osteotomy and proximal shortening, a solution for old hip dysplasia. Dr. Afshin. You need to unmute yourself and share your screen, please.
Good afternoon, everybody. Thank you very much, Vikas. It's my pleasure to have the chance to have my presentation. I want permission to start my talk. As you mentioned, I will talk about the new technique of proximal digastric osteotomy for patients with Grove type 4 DDH. After replacement of a stable component in anatomical position of femur must be a bit too long and needs to be shortened. In our country, due to some screening problems before, we have many cases with different kind of severity of DDH, and it is necessary to have some access to every kind of osteotomy, shortening osteotomy techniques from proximal to distal. There is some benefits and advantage of trochanteric osteotomy, and also some disadvantage of other kind of techniques as chevron or subtrochanteric or mid-shaft or distal osteotomy. But it is very important to know in trochanteric osteotomy some two important major advantages: excellent visualization of both femur and acetabulum, and performing trochanteric osteotomy abduction mechanism is preserved, and it's very important for post-op rehabilitation also results. In this technique, we ought to do digastric trochanteric osteotomy with attachment of abductors and also tensor fasciolata and vastus, and reattachment after shortening osteotomy to the host femur. It is the techniques I do in lateral position. And after doing osteotomy of and removing the femoral head, I do digastric proximal osteotomy. And after that, I do shortening osteotomy based on our planning, and the amount of shortening technique is the same. We do after that preparation of acetabular side, doing implantation of cup, doing implantation of femoral side. After that, we do reduction and reattachment of the trochanteric piece to the host femur with 2 or 3 wires. It's very important to do correct wiring technique, and you see here receiver for DDH Grove type 4 and doing digastric osteotomy, proximal shortening. I do many cases, and I think it's more than 1,000, but in this paper, I mentioned a total of 102 patients with Grove type 4 dysplasia underwent cementless total hip arthroplasty with digastric technique from 2009 to 2014 in Tehran, Iran. A prospective analysis of outcomes was performed in females, 90%, and in 9% in male. The mean age of the patients was 33 plus minus 7 years. And all the patients were evaluated clinically and radiologically with serial follow-up to obtain the possible complication of the patient. The mean modified hip RSS score improved from 44 to 80, and improvement was significantly very excellent. All the at the last follow-up, none of the patient had pain, and in radiography there was no osteolytic lesions, no presence of lucent line, no trochanteric union. It's very important. And I ought to mention and also emphasize that reattachment of trochanteric technique is very important. And if you don't do this correct technique, non-union is between 7 to 20% of the patient in some papers, as you know. And also there wasn't any change in inclination. All the patients have good activity at last follow-up. And you can see some patients with the technique. We reported the 7 complications in our patients. 3 sciatic nerve pulses, 2 patients recovered after 3 months. 1 patient needs some techniques of tendon techniques and tendon release and tendon transfer to dislocations, 1 after falling down and 1 due to extreme position, 1 intraoperative femoral fracture that handled intraoperatively by wiring technique, and 1 intrapelvic cup migration that was very important to know some kind of this complication. It's the patient that I mentioned that due to intraoperative femoral fracture, we did it. And also you can see some complex cases that we can solve the patient's problem by doing this technique. Trochanteric union is complete after 6 months in patient. And the next complication, I will finish in 1 minute, and 3 months on in some seconds. And it's intraoperative Cementless two-type arthroplasty using digastric osteotomy and proximal shortening demonstrate excellent short-term and mid-term outcomes in most growth type 4 dislocations, and it is recommended for this subject for this kind of patients. Thank you very much.
Thanks, Dr. Afshan. That's excellent. Any questions from?
I have a question, Dr.
Stan, go ahead.
Dr. Afshan, tell us, please, how do you restore leg length discrepancy in your patient with Crohn type 4 in cases when you have only pathology on one side?
It is, thank you very much, my dear friend. It's very important to know it is necessary to do prop planning correctly. As I showed, we do at first scanogram, and based on prop planning, we ought to know how much we ought to shorten. And it is very important to have a good stability intraoperative. And it is the same, but sometimes it is not everything, and it is necessary to use some shoe lift and so on due to stability problems, prevention. We ought to use some sizes of head that there is a little bit discrepancy, but it is not more than 2 centimeters in a unilateral case. In 2 bilateral cases, it is a little bit very, I think it is very simple cases than unilateral cases, that it's a little bit equalization of the limb is a little bit difficult.
Thank you very much, Dr. Afshan. So thanks a ton, Dr. Kalaivanan and Dr. Afshan, for your free papers. They were the 2 top selected from all the ones that were submitted to us. Now these 2 will go towards the final award, selection of the final award, which we'll announce at the end of the year. So what we plan to do is, from all these webinars, we take all the free papers that have been presented, and then the rewards committee will sit down and select the final award, which will be presented at the annual Congress. So thanks a ton to both of you. And with that, I now hand over to the moderators, Dr. Stan from Ukraine and Dr. Chain from Morocco, to take over the webinar and proceed. Thank you.
Thank you very much. Okay, dear colleagues, good afternoon. My name is Stanislav Bondarenko. I am associate professor and senior research scientist in Stenka Institute of Spine and Joint Pathology. And today we have 7 great talks connected with complex primary total hip arthroplasty. And I, with my colleague, Dr. Asi, will moderate this section. Okay, we will start from the first talk is Dr. Post from United States. He is a leader surgeon in complex primary and revision total hip arthroplasty from Rothman Institute, and he will share with us his experience connected with total hip arthroplasty at rheumatoid hip. Please, Dr. Post.
Good morning. Everybody can hear me okay? Thank you for having me. I'm joining you on a chilly morning from the East Coast of the United States. I'm Zachary Post from the Rothman Institute. My topic this morning is going to be replacing the rheumatoid hip. These are my disclosures, none of which I think are pertinent to the current topic. I want to just start by discussing rheumatoid arthritis. As we all know and are familiar, it's an autoimmune disease characterized by pain and joint destruction. Interestingly, in 2021, the etiology remains poorly understood. We do know that it is a combination of genetic and environmental factors. Characteristics of it include the deposition of IgG rheumatoid factor in the blood vessels, leading to vasculitis and synovitis. Interestingly, though, as many of us know, the rheumatoid factor is not an absolute, but the destruction of the joint remains. The joint destruction is mediated by monocytes, and it destroys all aspects of the joint, including cartilage, ligaments, and important to today's topic, subchondral bone. Joint symptoms or rheumatoid arthritis symptoms are characterized by tenderness, swelling, and stiffness lasting for more than 6 weeks. Commonly, morning stiffness persists for 30 minutes or longer. Much more than one joint is often affected. It typically affects the small joints, the wrist, hands, and feet, most commonly. And very often, the same joint is affected on both sides of the body. In fact, if you look at the Rheumatoid Society criteria, 5 of the following characteristics must be met in order to meet the diagnosis of rheumatoid arthritis: morning stiffness, pain on motion or tenderness, swelling in at least one other joint, poor mucin precipitation from the synovial fluid, histologic changes in the synovium, or characteristic histologic novels. Interesting to note that the rheumatoid factor is not one of the diagnostic criteria. That said, 80% of patients will have a positive rheumatoid factor. And it's interesting to note that patients who are rheumatoid factor positive have increased morbidity and, specific to hip replacement, have more poor outcomes and higher complications. The SED rate and the CRP are frequently elevated, indicating chronic systemic inflammation. And the joints very often have a steropleocytosis, which is increased white cells in the joint. Thankfully, it's a relatively uncommon when you consider the incidence of osteoarthritis. Rheumatoid arthritis is not as well spread or as common, 1 to 2% of the population. It predominates in females, 3 to 1, mostly females. The hand and feet are again the most commonly affected joints, but 25% of rheumatoid arthritis patients will go on to require lower joint arthroplasty, specific total knee or total hip. Rheumatoid arthritis management is something that has evolved even in the time since I've been in practice. When I was in medical school, biologic medications were not available and were not widely used. Now they become the mainstay. In conjunction with the DMARDs, they become the mainstay of modern management. They have not, interestingly, decreased the need for hip joint replacement. They have significantly changed the clinical course for rheumatoid arthritis patients. But if you look at the incidence of hip replacement in patients who have rheumatoid arthritis, in 2002, this study from 2017 showed that in 2002, 28.7 patients per 1,000 hips replaced in the United States were done for rheumatoid arthritis. This was prior to the introduction of widespread use of biologic medications. In 2013, once biologics had become the mainstay of rheumatoid arthritis management, that incidence had not changed, remaining at 28.6 cases per 1,000 total hips replaced. Again, this from a large NIS database in the United States. But the management has changed. There are a few preoperative and intraoperative considerations that if you're going to replace patients with rheumatoid arthritis hips, you should be concerned about. Specifically, this is the old medical school teaching. You got to be careful of patients with rheumatoid arthritis. They have very often unstable cervical spine. And so I think every anesthesiologist has taught this from day one, but anesthesia needs to be aware. If they are going to intubate patients with rheumatoid arthritis, they need to be prepared for possible bronchoscopic intubation to avoid destabilizing and potentially causing paralysis in the rheumatoid patient. Rheumatoid patients also need a thorough pre-op evaluation. Anemia and cardiovascular disease are common findings in patients with rheumatoid arthritis. But of all of these things, the most important consideration when approaching a rheumatoid patient is the management of the medications that they are taking prior to surgery. Again, as we mentioned earlier, the DMARD and biologic agents have significantly changed the disease course for rheumatoid arthritis patients. These medicines work by suppressing the immune response of patients, which is the hallmark of rheumatoid arthritis. However, in spite of that immune response modulation, complications for rheumatoid patients remain higher after total hip replacement than for others, including infection, dislocation, and readmission. And as you approach the patient with rheumatoid arthritis, discontinuation of the anti-rheumatic medications in the perioperative setting must be weighed against the risk of inducing a rheumatoid arthritis flare and the subsequent morbidity associated with that. This is a difficult subject to broach. There are no randomized controlled trials for guidance. There is one paper, and if the one thing you could take away from this webinar would be to look up this paper. This is the guidelines published by the American College of Rheumatology in conjunction with the American Association of Hip and Knee Surgeons. It is available both in the Journal of Arthroplasty as well as the Journal of Rheumatology. You should have this in your office and ready for a ready consultation. This is a collection of expert opinion. Again, no randomized controlled trials exist, but I will go through the main medications and their management. Specifically, DMARD management. Historically, recommendations included discontinuation of methotrexate, which is going to be the most common medicine that we will encounter in rheumatoid patients. The new recommendations, however, change that. Specifically, the recommendation is to continue the methotrexate. I won't go into the specific studies, but many studies showed that patients who discontinued their methotrexate had rheumatoid arthritis flares and increased complications. So the current recommendation is to continue the methotrexate through surgery. Moving on to the biologic agents. Again, here's a list of most biologics that are used throughout the world. The recommendations for biologics are that patients discontinue over one course of the cycle. So to use an example, Remicade, which is a common one, which is dosed every 8 weeks. A patient who is scheduled for joint replacement on July 1st and their Remicade was on July 1st should have their surgery after September 1st. And they should not resume their medication until 2 weeks after the operation. Glucocorticoids, again, historically the teaching was to do stress doses. Currently, the recommendation is for patients taking less than 16 milligrams a day, you continue your daily stress dose, or you continue your daily dose, with no stress dose. Surgical considerations, acetabular protrusio is more common in patients with rheumatoid arthritis. This is due to the weakness of the bone. I will not spend much time here. I know one of my partners is going to give an excellent treatment of protrusio, but just know protrusio is more common in rheumatoid patients. Seropositive rheumatoid arthritis patients are also more likely to have loosening and cup migration over time. Consider using highly porous revision type cups with multiple screws, perhaps not this many screws, maybe 2. But a lot of screws might be helpful to make sure you get biologic fixation and minimize migration over time. Cemented or cementless stems, this question comes up often. In the United States, cemented stems are not often used. Cementless predominates. For younger patients, the benefits of biologic fixation, at least in my OR, outweigh the risk to the fracture. I do use a collared stem in rheumatoid patients just to make sure we distribute the forces as much as possible. So in summary, rheumatoid arthritis management has improved with new medications. However, higher complication rates persist. Expert recommendation can guide the perioperative management of the rheumatologic medications, and rheumatoid arthritis bone tends to be more fragile and less stable after surgery. A modified approach focusing on implant fixation and stability is warranted. Thank you.
Thank you very much, Dr. Post, for your great talk. I have one question to you. In your practice, how often do you use for your rheumatoid patients bone grafting or augments for primary cases?
In the case of protrusio, we will use it often, but typically we will use the femoral head. We will ream the femoral head and use that bone graft to pack sort of the inner aspect of the acetabulum, and then try to get a rim fit on the external portion of the acetabulum to stabilize the protrusio. I would say we do that in almost every case where there's a defect medially.
Okay, thank you very much. Thank you.
And please, which approach do you use in these patients?
I use an anterior approach for almost all patients. I really don't think that there are any primary problems in rheumatoid arthritis that can't be addressed through an anterior approach.
Okay. Thank you very much.
Thank you. We will move forward. And it's my pleasure to welcome Dr. Filipenko, who will talk about replacing the dysplastic hip. So please, Dr. Filipenko, can you share your screen?
Это последний слайд. Включен? Нет, первый пост.
Right, while the screen is being shared, let's ask you one more question, Zach.
Yeah.
So anterior approach for all. I'm jumping from rheumatoid hip to approaches really. The transition, you were a posterior guy. What happened?
Well, actually, in fairness, I was a lateral approach guy. My personal feeling is if you do a mini posterior approach and you do it well, you really don't have much incentive to change. But as a lateral approach surgeon, I think there is some incentive I began dabbling in anterior approach about 10 years ago, but over the course of time, as I saw that patients were doing so much better with anterior approach, I converted to exclusively anterior about 7 years ago. Instead of sort of picking and choosing, though, we do everybody. And the change is important because instead of looking at patients and thinking who is good for anterior approach, you start looking at patients and why can't I do this from an anterior approach? And very soon it just becomes your approach.
And what is the rate of femoral loosening in your practice?
I'm sorry, I didn't quite hear that one. What was that?
What is the rate of femoral loosening as you use uncemented stem? Do you have a higher rate of femoral loosening?
In the rheumatoid patients or just from the anterior approach?
No, in rheumatoid patients.
Yeah, you know, I can tell you in my personal practice, we don't have a higher rate of loosening. I know that the literature does show that patients who have rheumatoid arthritis have a slightly higher rate of loosening. These are old studies, but using modern implants in my practice, we have not seen a higher incidence of loosening.
Thank you.
Thanks, Zach. I think we are ready with the next talk. Professor.
No, thank you. Hello, everybody. Now I am Dr. Filipenko from Kharkiv, Ukraine, and now we talk about replacing the dysplastic hip. Challenges in the total hip arthroplasty and dysplastic osteoarthritis acetabulum. Shallow endohypoplastic acetabulum with a deficient bone of the superior and anterior walls, often oval-shaped with a relatively narrow anteposterior diameter, increased antevation, lateralized high hip rotation center. Challenges in total hip arthroplastic and dysplastic osteoarthritis femur. Femoral canal shape is conical, canal flare index binoble. Excessive femoral antevation and valgus deformity, possible iatrogenic deformity of the proximal femur due to previous reconstructive surgeries. By choosing the femoral stem in crow type 2-4 DDH, the offset matters as some difficulties with the reduction of the femoral head may occur. It is preferable to use stems with short offset. In my work, I use classification crow. We have 4 types of DDH. It's more easy at first type, and the more severe at 4. Operative significance. Higher failure rate of total hip arthroplasty, higher the crow rating, the higher the complications. Treatment option of cup replacement, we have 2 points of view. First, this medial protrusia technique for replacement of porous coated hemispherical stable component without cement in a total hip arthroplasty. From our point of view, it's preferable to restore the hip rotation center with bone grafting of segmental defect. On this picture, you can see clinical case, patients 49 years old, crow type 1. In this case, we not very severe, and after replacement of cup, we plastic of defect upper wall of acetabulum with cancellous bone grafting. Particularities of acetabular cup fixation in hip dysplasia crow type 2. The segmental defect of the superior wall with uncovered area of the cup reaches 50%. Bone grafting requires fixation with screws. On this case, patients 45 years old, crow type 2, we can see method of fixation bone grafting, and 7 and 8 years post-operative results on the right and left side. Nice result. In crow type 3 DDH, the acetabulum defect with uncovered cup reaches 2/3 of its anterior part. In clinical case, patients 50 years old, crow type 3, and in this case we use large bone grafting with screw fixation, and result 3 and 3.5 years after operation. Also, developmental dysplasia of the hip crow type 3, patient 35 years old. We can see deformation of the femur after operation in the child. In this case, we use also plastic of defect upper wall of the acetabulum with screw fixation and special stem, Weiner cone, because another stem, in this case, it's impossible. Treatment option of DDH crow type 4 is the most difficult case. We have two different options. Different types of shortening osteotomies of the femur and soft tissue destruction with the use of external fixation. A clinical case, patient 31 years old, crow type 4, shortening femur, leg length discrepancy 5 cm before surgery and 1.5 cm after total hip arthroplasty. Next case, also crow type 4, 6 cm shortening of the affected limb before surgery, equal limbs after total hip arthroplasty. We can see X-ray after first stage of treatment, after second stage of treatment, and 5 years after operation. Patients 34 years old, crow type 4, right limb shortening on 7 cm. In this case, we also use a two-stage operation with external device, and after elongation of this limb, we use primary total hip arthroplasty. The results were 4 months after second surgery. Learning points. It is necessary to choose the optimal type and size of implants prior to surgery, to evaluate the anatomical features of the acetabulum and proximal femur, to perform the needed grafting acetabulum defects and an adequate soft tissue release to compensate for limb shortening in crow type 2 and 3. In dysplasia crow type 4, there is need to perform shortening osteotomy of the femur or a two-stage surgery with application of external fixation device. Thank you very much for your attention.
Thank you, Dr. Filipenko, for your very didactic presentation. How do you manage the leg length discrepancy, especially in stage 4 unilateral problem?
While Professor is answering that question, could we stop sharing the slides and load the next ones? Thank you.
We use two-stage operation in case we have unilateral pathology, and our elongation in external fixation during 3-4 weeks.
Okay, thank you. We move further, and I would like to introduce next speaker, Dr. Vijay Bose, Joint Director and Joint Reconstruction Surgeon in Asia Joint Reconstruction Institute, India. He shared with us his experience connected with total hip arthroplasty and ankylosis hip. Please.
Thanks, Chairman. My profuse thanks to SICOT Pioneer for giving me this opportunity to share my experience in the conversion of the osteous ankylosis to THR. So what do we infer from literature regarding this topic of a fusion takedown? The abductors are atrophic in most cases. Tunnelberg can persist for a long time, may need walking aid permanently. The strength of the muscles can improve up to 4 years. And the abductor, the quality seems to be the prognostic indicator for long-term results. It's technically complex surgery. High rate of complications has been described. Spontaneous fusion fares much better than a surgical fusion takedown, and there's a higher failure rate than primary THR. But the status of the gluteus musculature is the one factor that would determine how the patient will walk finally. So the traditional indications for fusion takedown has been fusion in an unfavorable position, pain in the back that we all know, bilateral fused hips, and inability to do activities of daily living. And now Callahan has published that more than 50% of patients who have a fused hip will have low back pain, ipsilateral knee pain, and contralateral hip pain. But like everything in life, things change with time. And now that we got good implants, we are beginning to understand the pelvifemoral hip biomechanics. And so today we'll say that anyone with a spontaneous fusion, like an Angspon, we can offer them a fusion takedown because we got good results with that. However, a post-surgical fusion, the traditional indications still apply. One must not jump in and do the surgery. So Angspon is very common in Asia in general, more specifically in India and China, very, very common disease. We see it on a daily basis, and we find these fused bamboo spines. And you can see that when you push in the patient, the limb is in mid-air. Very commonly, we do face this problem. Now, our experience is, so far we've done hip arthroplasty for over 1,400 hips, out of which 106 have had total osseous ankylosis in 87 patients. And the other indications have been rather limited in our series: surgical fusion takedowns 3, post TB 1, post head injury myositis 3, and post acerebral fracture 1. So out of the total 112 fusion takedowns, the complications are as follows. The dislocation, interestingly, is nil. There's been a superficial infection, deep infection, ectopic ossification, etc. So the issues that commonly described with the fusion takedown is soft bone, difficulty in locating the acetabulum, ectopic bone formation, sciatic nerve injury. You can have an iatrogenic femoral fracture, iatrogenic protrusio because you don't know where the socket is, damage to the abductor apparatus, and column disruption. Now, there are 4 important key steps that one follows. You can get a very good result, consistent results. And these are, the first thing is to do what we call as an intercalary osteotomy. So it's very important to remove a segment of the neck and not just do a one-plane osteotomy because it'll give you space to work in. The second thing is to find the pulvinar fat pad. Whenever you have a spontaneous fusion, it's almost a dictum that you will always find the pulvinar fat pad. In most cases, you always also find the transverse acetabular ligament. And then you assess the depth of the medial wall by putting a screw hole into it and using a depth gauge so that you don't perforate and cause a protrusion. And it's very important that you must keep the socket at the native socket level. You must not go high or go low. It's very common for you to stray in any plane. You can go medially, laterally, anterior, posteriorly, down, up. So you must be careful about that. And once that is done, it seems a straightforward procedure to do. And this is a video on how we do the intercalary osteotomy. So make sure you make 2 osteotomies and you're able to remove a wedge of bone. Therefore, once you remove a wedge, you'll be able to see the opposite cortex, and the opposite cortex osteomass and vision, not in blind way. Once that is done, then it's all the steps follow through. And finding the pelvic fat pad, here in this video, you can see that you start reaming on the head bone that's inside the socket, and use a combination of power reamers and hand instruments so that you don't over ream. And then find the pulvinar fat. This is an excellent tool, not only for the depth, but also to see where in 3 dimensions you are, whether you're anterior, posterior, inferior, superior, everything. This pulvinar fat pad and the transverse ligament will help you to identify. The third thing would be to find the depth of the mid-bone in the socket. Here, you, if you're not sure as to where the floor is, don't hesitate to make a drill hole, use a depth gauge, and make sure that you don't ream the middle bone in these young patients. Yeah. And it's very important, as I stressed earlier, to place the socket in the native location. So which approach to use? The posterior approach is preferred so as not to avoid damage to the abductor muscle. The abductor muscle is the critical issue here. So one must not do a hard hinge type approach. That's not a good news. Now, one thing that we have developed is the reduction osteotomy of the posterior trochanter. I will show you is a great adjunct to this surgery. And any kind of hard hinge or its variants must not be used because you damage the abductor mechanism and it can cause a severe limp in these patients. Now, what is the exception to this rule? When you have a fused hip in external rotation, then you have 3 choices. You can do a conventional trochanteric osteotomy, a trochanteric slide, or a combined posterior and anterior approach. And of the 3, the last option is the best option, the third option, because again, you don't want to disturb the abductor mechanism. So here is the posterior trochanter reduction osteotomy. You can see that you can hardly see the neck before you do the osteotomy. Then what you do is you take a saw and take that posterior trochanter off, which does not have any muscle attachments whatsoever. And then once that's taken off, you can see the amount of neck that you can see. Then the surgery becomes very easy to do. So I strongly advocate that in any case, there's a bit of external rotation, please do a posterior trochanter reduction osteotomy. Now here's a case in which even that didn't help. So we have to go anteriorly. So that's the posterior bit and that's the anterior bit. You go anterior and posterior but don't touch the abductor mechanism. And these are steps. You do a part of the osteotomy from the front, you do a part of the osteotomy from the back, and then you get a V-shaped osteotomy here of the remaining femoral neck bone. Then you do all your reamings, and then you put your socket in the native location. Now you can see that the hip arthroplasty both through the posterior and the anterior part of your approach. It's a combined dual approach. Go anterior and posterior and do not touch the abductor mechanism. Case examples are follows. You can see many case examples. We try to put the socket in the native position. Always try to put it in the native position. That's very crucial for long-term function of these patients. Now, almost all of spontaneous hip fusion patients will have spinal abnormalities. So you must take that into account. And now we know exactly what to do. The three indicators are important: the sacral slope, the pelvic incidence, and the pelvic tilt. And that's how it looks out in the real patient. 3 patients of ours, we have calculated all these indices. And based on these calculations of these 3 indices, we give suitable compensation. So there's a positional version, there's a functional version, and then a compensated version which lies between these 2 parameters. And now we find that our competent position has become much better once we have learned to appreciate these parameters. Now, here's an example of a post-acetabular fracture with osseous ankylosis. The operative steps, we've taken it down, and we've done the arthroplasty following the same steps. Here's a bilateral osseous ankylosis, a small socket size. In Asia, female patients have very small socket size, 44. And this is the operative steps. And because the socket is very small, we tend to use dual mobility in these. You can see this socket is slightly inferior. Here's a post-surgical fusion with a cobra plate. And here we have taken it down. We have used a trochanteric slide in this patient. One exception where we would use a trochanteric slide. And then here is the, again, we use a dual mobility because the abductor has been compromised. Here's a bilateral fused hip in a female patient. Female patients in axpon always have more severe disease, and that is her flex. She had a 100 degrees fixed flexion deformity, and that's her spine. And this is the perioperative steps, and that's after the first one was taken down. And in the gap of 3-4 days, we did the other done as well, and she's doing extremely well. So when do we use dual mobility in fusion takedown? 3 indications for us: small socket size, damaged abductor mechanism, surgical fusion, and previous surgery, and abductor is damaged. And inability to give adequate compensation for a deranged spinal pelvic parameter, because the spinal pelvic parameter is so deranged that you're unable to give a compensation. In that case, we'll use a dual mobility. So what is the functional status after fusion takedown? These days, with following all these steps, it seems to be excellent. Here is a patient. First has been taken down, second has been taken down, and that's the functional result that you can get. So in conclusions, hip arthroplasty is an excellent option to restore mobility in fused hips. Spontaneous fusion like an axpon gives very reliable, consistent results. The absolute functional scores are less when compared to standard THR. Most likely it's because of the other joint involvement. However, improvement is dramatic for the given patient and gratifying results can be achieved. It is important to take spinopelvic parameters into consideration. Technical factors as highlighted are very important. Thank you for your attention. I'll stop sharing now. Thank you.
Thank you very much, Dr. Boss. I have 2 questions to you. First, do you use dual mobility system for these cases? And the second, if you have a patient with bilateral pathology, what time between the first and the second total hip arthroplasty?
Yeah, so as I told in my talk, we have 3 indications for using dual mobility. One is when they have the spinopelvic parameters are terribly deranged, and then we can't give the compensation based on our calculation, it's just too much, then we use a dual mobility. Patients with small socket size, 42, 44, we see common, they'll get a dual mobility. And the third indication is when you have a surgical fusion or a previous surgery, and when the abductor mechanism was damaged, we tend to use a dual mobility. These are 3 indications, we don't use it unnecessarily. Now coming to bilateral fused hip takedowns, we will do the first side one day, and if the patient is fine, third day, 4th day, we do the second one. Or if we find that he has lost blood, he's not able to ambulate, then we'll give a gap of about 4 to 6 weeks. That's our protocol.
Thank you.
Thank you. I have a question. Do you use any electrical examination pre-operatively to assess the abductor mechanism?
It has been our consistent finding that when you have a spontaneous fusion, the abductor is just fine. Only thing is you must not iatrogenically injure the abductor. Otherwise, it's fine. So we used to do it earlier. We stopped doing it. And a patient with a surgical fusion, the abductor is gone anyway. So there's nothing for you to assess, but we'll use a dual mobility. So after the advent of dual mobility, we find there's no role for assessing the musculature by any EMG studies, etc. Thanks.
Because the problem of dual mobility is that the dual mobility does not relieve the risk of dislocation by lateral translation. And when you have a bad abductor mechanism, the problem is the lateral translation of the femur and the dislocation of the hip.
Dr. Shine, we'll stop the discussion here and we'll go ahead with the talks and we'll come back to this. This is an important point for discussion. We'll come in the discussion. So let's introduce our next speaker.
Move and welcome Dr. Enkin, who will talk about replacing the post-traumatic hip. So you can share your screen, please, and start. Welcome.
Good afternoon, dear colleagues. Can you see me?
Yes.
I am so glad to take part in this webinar and give the presentation on topic total hip arthroplasty after osteosynthesis of the acetabulum. I would like to start introducing to the Kyiv Regional Clinical Hospital, where I conduct my professional activities, where I am professor of the field of orthopedic. In this slide can be see our hospital and our surgical team. So let's go back to presentation. According to the previous slides of another authors, as you know, the meta-analysis treatment of cases of acetabulum fracture, long-time osteoarthritis incidence about 26%. Another study gives on information that the conversion of acetabulum fracture to total hip after arthroplasty is 28%. The main reasons leading to the osteoarthritis after the acetabulum fracture: acetabulum fractures and cartilage injury, repeated attempt to reposition of the femoral head, lack of anatomical reduction after osteosynthesis, femoral head injury, significant joint injury during osteosynthesis access, repeated attempt to reposition the femoral head. Total hip arthroplasty is a reasonable treatment option for a patient presentation with symptoms of post-traumatic arthritis or vascular necrosis with destruction of the femoral head due to the acetabulum fracture. Preoperative planning was based on fracture healing, fixator losing, prior fixator removal due to the placement of the acetabulum components, presence of laboratory evidence of inflammation, material and methods, retrospective analysis of treatment 42 patients with primary osteosynthesis of the acetabulum consequence of total hip arthroplasty. Research period from 2009 2016 year, average age 45 years old, follow up 60 months. Description of the patient depending on the type of fracture: 42 patient, posterior wall fracture 17, posterior wall and posterior column fracture 13, posterior column fracture 4, transverse and posterior wall 3, fracture of both column 5. Staging of approach to the total hip arthroplasty. One stage, 23 patients. In case with single stage approach, hardware removal and total hip arthroplastic were carried out in the same time. To study operation, 19 patients. In case to study approach, the first stage was removed of the fixator and the culture, and second stage was to perform the total hip arthroplasty after 3-7 weeks. The principle of studying of operation: signal of inflammation, laboratory and clinical, significant term from the date of operation, radiographic signal of losing of the fixator, placement of fixator in the area of installation of prosthesis components, fixation of the acetabular components of the prosthesis, cementless 34, cemental 3, reinforcing rings 5. Our cases: case 1, patient with fracture of posterior column and femoral head. We performed open reposition and osteosynthesis acetabulum with Coher-Langenbeck approach. After 2 weeks, patient has got post-traumatic arthrosis, aseptic necrosis. We performed 1-stage hardware removal and total hip arthroplasty with cementless cup, and have got 89 points by Harris score after 5 years. Next case, fracture of both column of the acetabulum. We performed osteosynthesis with 2 approach, ilioinguinal and Coher-Langenbeck. After 18 months, patient has got post-traumatic arthrosis, and we performed 2 studies approach to the total arthroplasty, and after 5 years, we have 91 point by Harris score. Third case, transverse and posterior wall fracture with left acetabulum, fracture of sacroiliac joint. We performed osteosynthesis acetabulum with Coher-Langenbeck approach and osteosynthesis 2 screws from sacroiliac joint. After 6 months, patient has got a septic arthritis with hip joint. We performed revision of hip joint, hardware removal of the acetabulum, installation the articulation spacer of the hip joint. After 2 months, we removed articulation spacer and performed total cement arthroplasty with hip joint, support ring, and bone autoplasty and alloplasty of the defect zones. We have got 86 point by Harris score after 5 years. Evaluation of treatment results. Harris score, primary 67 plus minus 14 points. After 5 years, 86 plus minus 14 points. Recovery rate for all patients without pain was 77 for 5 years. In 88 of patients, achieved a 5-year stable integration of the acetabulum components. Treatment result. Learning points. In most cases, with acetabulum fracture, with displacement of fragments, anatomical reduction and osteosynthesis of fragments has been reached. Even with anatomical comparison of fragments in acetabulum fracture, osteoarthritis of the hip joint may be developed. This occurs most often fracture, accompanied by dislocation of the hip, posterior wall, and posterior column. This tactic makes it impossible to carry out arthroplasty of the joint without significant technical difficulties, with the use of a full fluid bone mass for impression of the ball of the prosthesis. Thank you for your attention.
Thank you for your very clear presentation.
It's my pleasure to introduce Dr. Oliver Martin-Pena. He is consultant hip and knee reconstruction surgeon at University Hospital Infanta Leonor in Spain. A great scientist, a great specialist in total hip arthroplasty. Please, Oliver, welcome.
Thank you. Thank you so much for the introduction. I'm staying here in this fantastic project called Pioneer by SICOT. So my talk today will be about how to reconstruct in the protrusio acetabuli. Well, these are my conflict of interest that do not affect the following presentation. This term, protrusio acetabuli or arthrocatadesis, has been mentioned by Otto, and it's called Otto Pelvis also, in 1816, and in this paper they mentioned that the right acetabulum protrudes into the pelvis like a half an orange. This was the first definition of that, but usually you have to mention that the acetabulum goes medial to the ilioischial line, just going the acetabulum and also the femoral head sometimes. There are another definition of that, and it's mentioned that it should be, this protrusion should be more than 3 millimeters in males and 6 millimeters in female. And also there are some kind of classification, as you can see here. This is from Sotelo and Garza. And initially, there is a moderate protrusion when these half an orange go between 6 and 15 millimeters, and it's farther than 15 millimeters, this half an orange, it's called severe protrusion. So the natural history of this protrusion acetabuli usually is a central degenerative changes in this acetabulum, as you can see in this image from the paper from the Bern group. And this degeneration has been studied with the biomechanics, and there is an increase in the peak stress in the medial border when the patient is walking, and also in the posterior inferior border of this acetabulum when the patient is moving from standing to sitting. There are many causes of that. Some of them have been mentioned here. There is secondary protrusion that comes from infection, neoplastic, inflammatory disease that have been mentioned in the rheumatoid arthritis, and also metabolic, traumatic, like acetabular fracture or genetic. But mainly, we are talking about this primary idiopathic protrusion that usually take place in female, usually it's bilateral, and it has been mentioned that the origin of that is a fusion in the treated cartilage. So, in summary, there is an acetabulum who is very deep, and also you have to see in the femoral side that sometimes it's related to the coxa-vara and also increase in antetorsion. There are several treatment options: arthrodesis, excision arthroplasty, acetabuloplasty, or valgus intertrochanteric osteotomy, as you can see in the picture on your right. But we are going to talk about the old patients and the treatment with total hip arthroplasty. The objective of this replacement is to restore this abduction function and also to restore this anatomical hip center of rotation. So we have two options. One is to put the acetabular component in a medial place, as you can see here, but it has been related with a higher medial stress result for this position. And the other option is to put this acetabular component in a lateralized position and some graft in the medial wall. As I have said, if you put the acetabular component in the medial part, there is a 50% of the cases that can fail if the hip center is more than 10 millimeters from the anatomical one. So try to avoid this position in this medial and superior part. You have to go more anatomically, more lateral. So, and to get that, you have to put some graft in the medial wall. If you have a very grossly deficient in this protrusion, as you have seen in these pictures, you have to put huge bone graft in the middle, in the middle wall. And then usually you have to put all the femoral head and some additional fixation, as you can see here, just a bulk graft in the middle of the femoral head, and use these screws, or sometimes, as we have been mentioned before, you can put these reinforced rings with this graft in the middle wall. But usually you have to put in this moderate protrusion, more than 5 millimeters but less than 1 centimeter, you can use cemented cap in this lateralized position. There is some reports in the literature that have good results in the long term. But usually we are using these uncemented caps with some graft in the medial wall. These results in the long term have been published by the Mayo group with this hemispherical shell and bone grafting in the medial wall, with a survivorship of more than 85% in more than 15 years follow-up. So be very careful with these surgeries. It's a challenging approach for these hips, and you have to do a very nice preoperative planning, just with a CT 3D reconstruction, just to see how is the defect. Also in this moderate protrusion, and using these uncemented caps with graft, be very careful with the approach, because sometimes it's very difficult to dislocate this hip and to get the femoral head exposed. So you need to do this cut of the femoral net in situ, or sometimes you need a trochanteric osteotomy just to try to expose this femoral side nicely. And also sometimes, as you can see in the video, in this posterolateral approach in the right hip, you need a recutting or try to get a better expose of this femoral head to do a removal of this femoral head with this screw cork. So also you have to be ready to get the graft, usually from the femoral head that you have removed from the hip. You can take with the Ronger, or you can use this reamer to get this graft to put in the medial part of this acetabulum that usually is weak. So you can put the graft like you can see in the video, and then you can compact a little bit and do some impaction in this area, and just to get the graft in the medial side, just to put the cup, the uncemented cup, in a lateralized position more anatomically. That's important. And as I have said before, you can reinforce with a screw, a couple or 3 screws of these cups. So when you have less than 5 millimeters in this protrusion, this mild protrusion, sometimes you don't need this graft, or just with a standard uncemented cup is enough. And sometimes you can use some screws. And be careful again about the femoral side. As you can see in this picture, this is a patient that they have done a valgus osteotomy in the past, in the childhood. And we remove this plate and screws, and we try to use this modular stem just to avoid this anteversion and this varus position sometimes. So be aware about that. And for sure, in the future, with the new technologies, we have a lot of support to put the cup in the anatomical position more lateralized. So our learning points in this protrusio acetabuli is a challenging surgery. Sometimes you will have a difficult approach and be ready for this neck cut in situ or trochanteric osteotomy. You have to restore the hip biomechanics in these patients and improve the pain, and be ready for morcellary bone graft in the medial wall, and also to put the cup in the lateral position, usually an uncemented cup. So thank you so much for your attention.
Thank you very much, Oliver, for a nice presentation. I have 2 questions to you. First, in cases when you could not achieve a stable primary press fit fixation of your cup, what do you do? What your second option? And in cases when you have a coxavara, do you use in your practice lateralized offset stem?
Yeah, thank you so much for your question, Stanislav. Very nice questions. The first one is usually you can get fixation all around the rim. Remember that these acetabulum are usually not very big ones, and it's like a clock shape. So you have these problems just to put graft in the middle wall, in the medial wall, but in the periphery, I mean, you get a very nice press fit usually. You can be ready with these revision shells in the OR just in case. But to be honest, I think it's very easy to get a good fixation all around, just anterior, posterior fixation, and trying to forget about the medial one. And about the coxavara, is a very nice question, because sometimes you have this problem. But and in these cases, I use these modular stems that I have showed you before, so you can adapt with that. But if you do a lateralized position of the acetabulum, you are getting everything out. So you will restore this position of the adductor muscles, and you don't need a varus stem usually. But again, if you have one option in your OR, it will be more than happy.
Thank you very much.
Oliver, thank you for this talk. It was beautiful. Just one question. What is your post-operative management? Do you permit a full weight bearing after the surgery?
Another very good questions. With the new fashion of rapid recovery protocols, it's like an offense to say that the patient cannot put weight bearing after the surgery. So, but to be honest, always we allow the patient to do weight bearing with crutches. So it's a partial weight bearing. Usually are young people, so it's very easy to manage with crutches and partial weight bearing. But also, usually you have a very good press fit with this peripheral one. So I try to forget the medial gap.
Thank you very much. We will move now, and we will welcome Dr. Zazirnil from Ukraine. who will present the value of a 3D CT scan in planning for the complex primary total hip arthroplasty. Please, Dr. Zazemil, can you share your screen?
Is devoted to the value of the 3D computer tomography scan in the planning for the complex total hip arthroplasty. Computer tomography itself has been used for planning joint replacement for over 30 years. Preoperative planning with 3D computer tomography is a more recent concept in modern orthopedics. The surgical planning potential of the 3D CT was first explored for the craniofacial surgery in the 18th, and after it was found that 3D reconstruction could be generated from the computer tomography data. Line graphs showing the growing trends of the use of 3D planning in the literature during last years. Typical process of 3D preoperative planning is computer tomography, decom, segmentation and 3D reconstruction, surgical planning, selection of implant, if need 3D printing, surgical procedure, postoperative evaluation of implant position. Accuracy of 3D preoperative planning is in component size prediction and restoration of biomechanics by leg length difference, femoral offset, center of rotation, femoral stem position, and acetabular cup position. All this should be restored in the total hip arthroplasty to minimize complications such as pain, instability, wear, and abnormal gait. And benefits of 3D planning. Technical benefits. 3D surgical computer tomography based planning provides information on the quality of the bone, the evaluation of the contact state of the implant and the host of bone, and the differentiation of the cortical and calcaneus bone. The technical benefits mentioned above apply for patient too, since a more accurate surgical procedure leads to a more accurate restoration of biomechanics. Since computer-assisted orthopedic surgical software has enabled the visualization of pelvis anatomy, surgeons can accurately assess all the details, anatomical characteristics, and prepare for any possible intraoperative complications. Additionally, component size can be easily defined by either the software or the surgeon to match the native anatomy. This has been proven to scale down the intraoperative question regarding the size of hip components, which in turn may reduce the component repository. Orthopedics preoperative planning software usually entails a certain annual cost to hospital. It's a barrier. Direct cost of 3D preoperative planning per patient consists from 53 till 116 €. Next barrier is radiation dose. Computer tomography-based orthopedic planning software is associated with the concern of increased radiation exposure. Recent evidence support the finding that improved scanner and hardware, as well as a dedicated computer tomography protocol, may further reduce computer tomography radiation exposure to a level comparable to that of conventional radiographs without compromising image quality. The complexity associated with learning new technological program constitutes a significant barrier that 3D preoperative planning encounter. As such, both medical personnel and engineers may need to put effort into learning. Knowing how to use a 3D specialized planning software is not translated to successful preoperative planning. A necessary step is preoperative planning is the anatomical landmark extraction. Most of all total hip arthroplasty planning software have 3D reconstruction functionally and allows positioning of the acetabular component on the axial, coronal, and sagittal view. This is also possible with stem, anteversion, and position of the femoral head, offset, and leg lengths. Some publication about value of 3D preoperative planning show the better result for such a planning. Accuracy of acetabular cup in the non-dysplastic group was better, but the difference in the accuracy of the femoral step between the two groups was statistically insignificant. 3D planning was performed with the dedicated SICOT-UAOS planning software to determine stem and cap size and position, plus 3D anatomical functional parameters in patient various in leg length and femoral offset. Component size planning accuracy was 94% within one size for the femoral stem and 100% within one size for the acetabular cup. There were no significant difference between planned versus implanted femoral stem size or planned versus measured changes in leg length or offset. Biplateral radiograph plus SICOT-UAOS planning software showed good reliability for predicting implant size, leg length, and femoral offset, and postoperatively provided a check on the navigated surgery. Compared to previous studies, the predictive results were better than 2D planning on the conventional radiography and equal to the 3D planning on computed tomography image with lower radiation dose and in the weight-bearing position. Another publication about accuracy of 3D planning. In the 3D group, the accuracy was twice higher with 96% for cap and 100% for stem and 93% for the head. Accuracy of planning with 3D programs gives better craniocaudal planning for the femoral head center and better femoral offset planning. Also, we received the better craniocaudal planning of the center of rotation and better mediolateral planning of the center of rotation. We used 3D scan planning for the severe cases of total hip arthroplasty, like hip dysplasia, like post-traumatic arthritis and revision hip surgery, for prepare the better and more equal reamer and for better hip components. It's give us the opportunity to receive good clinical and radiological results. The 3D computed tomography preoperative planning improves component size prediction, restoration of biomechanics, and leads to minimize complications such as pain, instability, wear, and abnormal gait. Thank you very much for your attention.
Okay. Okay, now we have 10 minutes for discussion, and I have one question to all faculty. In cases of post-traumatic pelvic discontinuity, what are your treatment options? What do you do, guys, in this case, please?
You can start with Oliver from the screen. Yeah.
Yeah, I can answer that. In these cases, you have to be ready for a fixation of this discontinuity. So you have the several options. Actually, I think the revision cell with the cup cage construction is a good option. But also you can do a fixation of the posterior wall, for example, with a plate or the pelvis reconstruction plate or whatever. But you have to be ready to do a fixation of the discontinuity.
I totally agree with Oliver. If you have a possibility to put a fixation, an internal fixation of the posterior column, this is the best solution, and you can do put a cage in the acetabulum, or we can use the Kerbal cross that has a distal hook who goes in the teardrop, and with a plate proximally that you can screw on the upper side of the acetabulum.
And it's a hot topic. I agree with you. This is another option. But the problem sometimes is with this curved ring, you cannot get fixation to the bone just with screws. It's not an integration in the secondary. So I would prefer this kind of new porous metals just to try to get a secondary fixation of this acetabulum in this discontinuity. But I think it's a very good option. Yeah.
Are any of the faculty familiar with the distraction arthroplasty? Anybody done that technique with a very large cup with the porous tantalum metal and multiple screws?
Okay.
Oliver, have you tried that?
Yeah, I know this technique. I have seen Wayne Paprosky doing that several times, and he's so enthusiastic with this technique. But to be honest, I have some concern about how to manage that. Maybe because I'm not very experienced with that, I don't do it very well. But I prefer to do the other options.
Yeah, I agree with you. I think the most important thing is to get biologic fixation. You know, the traditional cages, I think that's the main limiting factor is that there's no fixation. You know, there's nothing connecting it to the bone. So I think the cup cage and/or the distraction technique is my preferred approach.
There's a question coming in from the audience. I'll just read it out. This is for Dr. Oliver Marine Pena. What is your stem option for a short patient and a very short femoral neck? So pretty much you highlighted that on a Coxa Vara, but
Yeah. I try to avoid this topic because sometimes it's not easy to manage. But there are some custom made stems that you can use in these cases. The 3D printing planification is a good idea to see these problems, and then you can use this kind of custom made implants. And there are also some these plastic femoral components that can use in these cases. But it's a very interesting question.
Thanks, Oliver. Over to you, Stan.
There is a question of the audience for Dr. Bose. Is he with us?
Dr. Bose has had to leave, so he's moved on.
Because there was a question concerning the position of the patient in fused hips. If there are any tips or tricks to position the patient? Anyone would like to answer?
I think he probably comes with the maximum amount of experience, so we can move on that question. Yeah. Let's go to dysplasia. Professor Waldemar had an excellent talk on dysplasia. In terms of bulk femoral allograft, or in terms of using metal, tantalum metal or otherwise, what is your preferred option for the high crows? You showed that beautifully in your talk. Do you have any issues with large femoral heads being used as a bone graft and resorption over a period of time? Professor Filipenko?
On microphone.
Yeah.
Okay, it's a very good question. We use usually in the young patients bone grafting. During first operation, we have this bone grafting because we remove head of the femur. But in case of rheumatoid arthritis, like in one our colleagues said, we augment from metal because in many patients after bone grafting, during total hip replacement, have losing of cup because this bone grafting is destroyed during function, and we have these cases about 20-25% in my group of patients, and in the last time we use augments. It's better.
Okay, thank you.
I have a question for Professor Filipenko as well. Please, when you when you decide to do your trochanterotomy, you put in your total hip. How do you manage to put back the trochanter on the femur? What are the landmarks you use to position the trochanter, knowing that you have modified the anteversion of the femur?
Yes, of course. We made osteotomy of great trochanter only in case when we have patients with iatrogenic deformation during surgery before. And this body of our osteotomy is very difficult problem, and we use planning before operation with use 3CT computer tomography.
I have a question to Dr. Post. In cases of when you perform total hip arthroplasty in patients with rheumatoid arthritis, and when you have problems with the bone quality with severe osteoporosis, do you use cemented cup, or you always use only uncemented?
Yeah, we have never used a cemented cup. I won't say that we wouldn't do that. It's just that we haven't. You know, my experience with cementing cups is so limited that I think that the outcomes, even in the setting of severe osteoporosis, may be better in my hands with a cementless cup than it would be with cemented. I just am not familiar enough with the technique. And I think that's probably true in the US in general.
Oliver, your point?
Yeah, I agree with Zachary. Indeed, in the literature, you revise the publication about that. Usually are coxa protrusa acetabuli, and the results in the long term with the cemented and uncemented are very similar. So you have to do the technique that you mainly do with your hips and try to do in the lateral position. That's more important than doing cemented or uncemented. So I think both are good options if you do it correctly.
On this topic, Oliver, I wanted to ask a question of you. Do you have any experience using the tantalum hole cover? I don't know what to call it, the Zimmer hole cover. Have you seen this implant? Instead of the bone graft, you put this tantalum augment along the medial wall.
You mean this kind of cookie?
Yeah, we call it a manhole cover, but I don't know that it has universal translation.
I mean, it's like a cookie, right? So yeah. No, I have never used that, and I'm a little bit concerned about if you go into the pelvis, especially in these very deficient walls. Also, in the literature, you are analyzing the impaction grafting from the people from Nimega or Exeter. They are now starting to stop using this medial mesh. So because with the graft, if you put the graft in 1 centimeter size and impact that, sometimes it's enough to get a good stability of this graft in the medial part, especially because they are not working like a weight bearing. It's just to reinforce the medial wall. So maybe this kind of cookies or the reinforcement in this medial part is not so important in these cases where you get the fixation all around the ring. Yeah.
And the results of reformation of the medial wall, Zach, with the impaction bone grafting technique is pretty good. You know, you've got the femoral head there, you can mosselize it, put it in there, so it reconstitutes it fairly nicely. So why would you want to use something like tantalum?
Yeah, I agree, and I'm not advocating for it. I was just questioning. Yeah, I think in our results too, yeah, that medial bone graft incorporates almost 100% of the time. I mean, it is a very good technique.
So just in case, I have put in my presentation, just in case you have a very huge deformity, deficiency in the medial wall, you can use your femoral head, just removing the cartilage and put that in. It's not a very frequent technique, but you can use it, and it's like a very structural graft, like a bulk graft inside. So it's one option, and cheaper than this cookie.
So we're coming to the end of our webinar, and I'll hand over to the moderators to present the final slides. But before we do that, you know, excellent talks from all of you. if there was a young attending who's starting his practice in hip surgery anywhere in the world, and he's going to be doing these complex hips, let's get one tip that you want to pass on to this young attending who's starting off in your talk. So Oliver, let's start with you. What's one tip that you want to give this young guy?
I repeat again, to put the acetabular component lateralized in the anatomical position and put some graft inside, and try to forget the medial part and get the fixation all around laterally.
Thanks. Zach?
Yeah, my one tip would be use more fixation than you think you need. You hate to look back and wish you had used more when you could have done it at the time.
Thanks. Dr. Filipenko, you'll need to unmute.
Mm-hmm. Что?
One tip, yes?
Yes.
What one tip would you want to give this young attending who's beginning to start doing dysplasia surgery?
Oh, one type of crow.
No.
No.
One main recommendation for young
recommend
children connected with dysplasia.
The main recommendation is planning before operation, because during operation we can have many problems if we not ready for different situation. And last time we also use 3D print models, and after that we can planning a small cup, because in any case we have cup size 34, 40. It's very rare. We use this cup only one or twice per year. But not problem only with cup. We usually talk about only acetabulum, but during my opinion, the problem also we have with femur, because we have deformation of femur in any case, and we must in any case do osteotomy for correct deformation of the femur after operation previous.
Thank you, Professor. And Professor Ankin, one tip from you?
No, I think my opinion, it's operator with the first, it's small cup, as you say, Professor Filipenko, and put the acetabulum in center of rotation. The long the femur, no, I like distal osteotomy if it's crown 4. I'm sorry.
Thank you. Okay, right. Final slides, please. Thank you. You've got the summary slides. Stan, you can go ahead.
Okay. Thank you very much for all, and to summarize several important points for every presentation. Okay, for dysplasia, it's very important to perform reconstruction of the acetabular defects and to put a cup with restoration of center rotation. And if we have crown type 4, there are two options. One option is shortening osteotomy of the femur, and the second option is two-stage procedure with the external fixation device, which allows us to restore leg length equality. Okay, which the key points to ankylosed hip. The first, hip arthroplasty is an excellent option in restoring mobility in fusion hips. Functional results may be less compared to standard total hip arthroplasty, And if the technical considerations are taken into consideration, one can achieve gratifying results. Okay, the key points connected with post-traumatic hip, it's important to try to restore anatomy of the acetabulum before total hip arthroplasty, and it makes surgery more easy, and in cases, if it is possible, to perform biological restoration of acetabular walls with insertion highly porous cups on the level of true acetabulum. Okay, protrusive acetabulum. Total heel arthroplasty in this pathology is a challenging surgery, a difficult approach with difficult femoral head dislocation, preferable to perform sandwich osteotomy, muscleized bone graft to reinforce medial wall, and anatomical lateral position unsymmetric cup are preferable. And about value of 3D CT scanning for a complex primary THA, it improves compartment size prediction, improves restoration of biomechanics, and leads to minimize complications such as pain, instability, wear, and abnormal gait. And
so post-webinar surveys are very important to us, and we would like you to please fill up these forms if you want your certificate of attendance, and then we'll send it from the headquarters. And next slide, please. Please do join us for our next webinar. Now, this is another important one. Elizarov's birthday, 100th birthday is being celebrated, and we are partnering with the EOF for this webinar on the 24th of April. So please do join us for this one. It should be a cracker of an event. Thank you very much to all our speakers from around the world and also from Ukraine. Thank you very much to AK Medical and the Ukrainian Orthopedic Society for partnering on this webinar. Thanks a ton and have a lovely Easter, all of you.
Thank you very much.
We'll just stop the live presentation now.